Welcome to the Operators, a Caesar Health podcast where we talk to the people actually running medical practices, physicians, office managers, front desk staff, and everyone in between. I'm Atoli, and today I'm really excited for this conversation. Our guest today is Dr. Matt Astin. Matt is an emergency physician at Navicent Health in Macon. Am I pronouncing that right? Is it Navicent?
Correct, yes.
Out of Georgia, where he's been working for almost 12 years through Apollo MD. But what makes Matt's story interesting is how many hats he wears. He's the medical director at the Macon Volunteer Clinic, a free clinic that's been providing care to uninsured working adults in Middle Georgia since 2003. He's also the medical director for Mercer University's Master of Athletic Training program, a team physician for Mercer Athletics and the Macon Mayhem hockey team, and he runs the paramedic program at Central Georgia Technical College. Beyond clinical work, Matt is deeply involved in medical education. He's a co-host of Rebelcast and an associate editor at Rebel EM, one of the most respected FOAM sites in emergency medicine. And he's also a theater actor. He's played Shrek, Daddy Warbucks, and Dr. Frankenfurter on stage. We'll see if we can get into that today as well. Matt, welcome to the Operators.
Thanks for having me, Anatoly. I'm glad to be here.
Let's start at the beginning. You went to Mercer for undergrad and med school, then East Carolina for combined EMI and residency, and then came back to Macon. What drew you to emergency medicine in the first place?
Mm. The story goes way back to when we're going back to the 1980s. Michael Jackson's Bad album had just come out and had it on cassette tape. Yes, there are things as cassette tapes. And while I was trying to open this in this hard plastic case using a pocket knife, I sliced my finger open. I'm,
Damn.
8, 9, 10 years old. So they take me to the local emergency department. My mom does, and I have to wait for several hours for my pediatrician to come in because there was no emergency medicine doctor in the hospital. So, yeah, being that young, that left a mark on me. Having to wait, for somebody to come do this. Um, so, so progressing on through all the years, I knew I wanted to do medicine, and then the opportunity came, where I got to go to medical school and then be in residency. During medical school, I really enjoyed being in the hospital with really sick patients. Um, my first internal medicine rotation as a third year, when our first call night going down to the emergency room, I was like, this is home. I just enjoyed being there with all the fast pace, the problem solving aspect where you don't know what's going on with a patient, the mystery involved with it. But I also liked the inpatient side as well. So that's why I pursued a double board certification residency in emergency medicine and internal medicine. So I did that at East Carolina. It was a 5-year program. But then after that, I came back to Macon. So I went to school. I've got 5 degrees from Mercer University. Both of my kids, one has already graduated, and one's there now. So this is home. So I just came home and I've branched out from there. So.
That's awesome. And at which point during your training did you realize this was your path? Was it maybe a patient, a shift, or a mentor that made it click for you?
Not necessarily. It wasn't a single point. Just going through the clinical training that was there. But during that clinical training, the opportunities came up, and I guess it was somebody saw something in me at some point to push me more toward a leadership side. Um, I still, no matter how high up I get in leadership, I'm still going to practice clinically because I enjoy interacting with the patients and, in the emergency room, I'm seeing them at their lowest points and providing some kind of hope for them when I can, and if not, being there to support them in their dark times. So um, I became the chair of our resident council in residency, and I did that for 2 years, which is unusual, but I was in a 5-year program, so I was there for a long time, and then it just kept climbing from there.
And so now, how is your time split? Is it like 50-50 between the clinic side and then more so the leadership and teaching side, or how is it split percentage wise?
That is a percentage wise. I don't have an answer for that because it changes. I work roughly 8 to 10 emergency medicine shifts a month at the hospital. We are a level one trauma center, so we're pretty busy. So the rest of that time, I that I'm not working clinically, I'm doing administrative and teaching stuff. Throughout the time. In the fall, I do teach a class at Mercer, but only during the fall. The rest of the time, I'm there, taking care of athletes when they need things. The students are there. I'm a resource for them. So I technically am working 7 days a week, and I've been doing that forever because I mainly work my emergency medicine shifts on the weekends. So during the week, I'm taking care of administrative things. I do not see patients at the volunteer clinic. I'm just the medical director and as a resource for the volunteers. My patient care is only in the emergency room, but other than that, or the athletes, other than that, it's making sure all the administrative things are taken care of, making sure everybody has what they need to take care of their patients or to learn in order to take care of their patients. So
Got it. And myself, having been raised in Canada, I don't think we have. I've never heard of volunteer clinics before because for us, healthcare is free, quote unquote. And I say quote unquote because ultimately in Canada, we end up paying for it, not in money, but in time, I think. Even for me, like a basic injury from kickboxing in my shoulder, I think it was like 11-month wait time for an MRI scan. Um, Tell me a little bit more about the Macon Volunteer Clinic. They've done over 115,000 patient visits since 2003. What does the operation look like today?
yeah, so what we are, we're just almost 1 year into our new building, where we got a lot bigger. So the volunteer clinic, we see working adults, only adults that have no insurance. There are strict, eligibility criteria. So you have to have a job, no insurance. You cannot make more than a certain percentage of the federal poverty level. So that's how we get our patients. We only see adults 18 to 64 because under 18 you're eligible for pediatric, Medicaid type stuff. Over 65 and you get Medicare. So that's how we see those patients. And so it's a strict criteria, and we have expanded. Originally, it was just the county that we're in, but we've expanded to this county and six surrounding counties. And most of those other surrounding counties are very rural. They may not have a physician in the county. We've trying to branch out for that. So the way it works is we have clinic 4 days a week, 4 half days a week, because our providers are volunteers or they are retired. So they're taking time out of their regular day to come and volunteer their time to take care of our patients. All of our services are free to our patients that we provide here. If we have to refer them out to a specialist, we have agreements with them. So either that care will be free or at a greatly reduced cost to the patient. And so because along those same lines, my providers again are donating their time. We don't. I have one full-time nurse practitioner that works. She's our only full-time staff. Everybody else comes in on their free time or after like today, I've got a dermatologist coming after he closes his practice. So he's going to come in and see patients. So all these volunteers are covered under the state of Georgia's volunteer laws as far as malpractice coverage. So this is a great place to kind of serve as a safety net for people for their primary care.
Wow. And so the clinic runs on volunteer physicians, nurses, staff. How do you coordinate 150 plus volunteers across different schedules and specialties?
I have one employee that her job title is volunteer coordinator. That is her whole job is to get these people in, get their applications for the volunteer network, to be approved, and then coordinating the schedules. That is a full-time job in itself. So
Abs-
I spend a little bit more time on trying to get new people to come in, trying to recruit, so to speak, different providers, different specialists that to kind of fill gaps that we have.
And then in the emergency department context, paint me a picture of your ED at Navicent? How many beds? What's the annual volume? What's the patient population like?
Yeah. So our population is very similar to the volunteer clinic patients. Some of them, obviously a little bit more people with insurance, but we are a level one trauma center, nonprofit. So we are the kind of safety net for the area. We are a tertiary referral center, so we get things coming in all the time. So we have technically 47, 48 rooms, but we're up to about 65 to 70 care spaces that we utilize. That's an operational headache that we have trying to get staffing for all this and finding places to put patients. So we see roughly 185 to 200 patients a day. Um, that is not counting pediatrics because we have a separate pediatric emergency department. So they're seeing 50 to 60 patients a day. So,
And I saw that you were the director of social media for Apollo MD for a while. What was that like? And um, what is generally like the sentiment of physicians and the staff around social media? Generally, are they like more skeptical of that sort of thing, or are they more open?
yeah, that role has kind of disappeared from Apollo MD. But when I was there, doing that, it was more of a just reaching out and engaging. It has become a little bit more accepted in the especially the emergency medicine world over the past decade. The social media is a way a lot of new research is being put out. Conversations are being had over social media. That's how I've made a lot of contacts with. I mean, I've got friends in Canada because of social media. So it there's a lot of perception in the public, the negativity thing about social media. From the medical side of it, we don't have as much because we're looking for specific things with it and having specific conversations. It is a headache for us when, you know, um, patients coming in. So I saw this on TikTok, that type of thing. But from the user's aspect of the provider, it is a beneficial thing that we're using more and more.
And then what was the goal to engage more patients? Was the goal to engage more staff? Like what's the whole goal behind running a social media for an organization like Apollo MD?
Yeah, the goal for that was much more since it's Apollo MD is a contract management uh, company, so they just provide provider services to different hospitals. So the purpose for that was more visibility in the market and potentially recruiting. So
Nice, nice. And then going more so into the operation side of things, what's the biggest operational challenge you deal with the ED right now?
the biggest operational challenge, and this is not isolated to my facility, this is, everywhere, is the fact I cannot see patients because I'm holding admitted patients in the department. So there is no space for the admitted patients to go upstairs because the hospital is full. So that backs up our people. So our waiting times are much greater. Our patient satisfaction goes down, and the chances for errors go way up as well because
Mhm.
the wait times and not being able to get to people. So.
And like, what's the longest you've seen patients waiting for beds?
Well, again, kind of break that down. ICU beds are a little bit different animal because that's limited as opposed to like a general bed. But I've had patients sitting in my emergency department for 55, 60 plus hours waiting for a bed upstairs, not an ICU bed, a regular bed. And then that turns around and prolongs the emergency department patient wait times. I've come in first thing seeing a patient that's been in the emergency room waiting to be seen for 19 hours. So
Wow. And Would you say that's a norm either across the state or across the country?
Um, those extreme numbers are not normal. That's pretty rare. But the norm is usually a, you know, 18 to 24 hour delay in getting to a room upstairs at a minimum. Um, uh, I could probably pull my tracking board up right now, and I'll have, this is a Monday after it is Monday. Yes, it's a Monday afternoon, so it's going to get worse and worse. Probably in about 3 or 4 hours, I will have 35 to 40 patients in the department that are admitted, but they're boarding because they can't have a bed upstairs. And that will carry over into the morning and tomorrow during the day, which, we try and get things sorted out and smoothed out the rest of the week and to the weekend so we can start the whole process over again on Monday. So,
And having been in this ED for over a decade, what's been the biggest change operationally? What's gone better? Maybe what's gone worse over the past decade?
yeah. Our physical landscape is helped us a lot. Because we've opened up different areas, we've remodeled a couple of different areas to open up more care spaces. So that has helped a lot, and now allowing us to um, uh, get in front of more patients to see them. We've also had some systems changes as well related to our trauma services and who's available and when they're available and how we get in touch with them. Um, since we're also a referral center, our transfers that come in, a lot of them, um, the vast majority of them do not go to a floor bed. They come to the emergency department. So that's another bottleneck that we have. So taking up our beds. But um, but the process with that is, they're coming to us because they are sicker than wherever they're coming from can handle. So we are there to take, kind of manage them up front. So those are good things. Now, the some of the bad things are a lot of the staffing models on the nursing side coming from different companies, administrations. There are questions related to that. Um, if you look at productivity models in nursing and in hospitals, those things are great for a med surge floor. It does not work in an emergency room where your capacity can fluctuate on a minute by minute basis. You know, you can't staff a department on productivity if the productivity is going down and you send patients home, or send nurses home just for hours and that type of thing. And so then you don't have the available people needed when the the school bus has an accident and you get 40 patients coming in one time. So so the mindset of productivity is for staffing is a detriment to emergency medicine.
So it sounds like there's a lot of fluctuations, which is tough to pinpoint um, and
Yeah,
make sure that the staff are useful while they're there.
there are trends that you can monitor, and we keep this data. We know how many patients come in on a average on every day what the average patients we see, but we can also map this out on an hourly basis, what's the average number of patients that come in per hour. And you
Mhm.
can see a trend, line, we know that more patients are going to come in, patients start coming in late morning or on lunchtime and it'll peak mid to late afternoon. And then as you get later into the night, it tapers off again. So, um, but that's normal coming in, through triage, that type of thing. You're always going to have those outlier events. Doesn't necessarily mean a mass casualty event, but you'll have little, what we call boluses of patients coming in at any particular time outside of that normal trend.
And then when it comes to the volunteer clinic, running a free clinic seems like a different type of beast. What are the biggest operational headaches at the Macon volunteer clinic?
Yeah. Well, my biggest thing is getting patients. So we have a very strict criteria. So getting patients actually come is tough for us. Um, so actually, our patient numbers have actually gone down. It picked up a little bit since COVID. It still is not where it was before COVID. That probably has to do a lot with the health insurance marketplaces around. So a lot of people are getting insurance, and so there's not as many. But um, so operationally, getting those patients to come see us and how that affects us operationally is we staff according to what our schedule is. Well, if we have a full schedule of patients and half of them don't show up, that my volunteer gets frustrated with that, so they'll stop coming. So,
Mhm.
that's my biggest thing. And related to that is, once we do see them, and back to what I mentioned earlier, is finding these specialists that we can refer to for free or reduced services. I've got several subspecialties that I don't have to work with us, and these are things that our patients need. I'm working with trying to get cardiology to help us. We have patients that need stress tests or some kind of cardiology evaluation. We're finally getting some resources to help us with colonoscopies for screening, colon cancer screening. But again, this is through a kind of a free clinic network. I don't have a local provider that's helping me with this yet.
Mhm.
So those are things I'm working with. So
And then when you say like um, getting more patients into the clinic, is it that not enough patients are eligible for these volunteer services, or is it that they're getting signed up, but then for whatever reason they aren't able to make it physically? Like, where's kind of what's causing this challenge?
yeah. So the visibility of one getting new patients to sign up is tough. Um, a lot of people, even though we've been here for 20 years, still don't know about us. Um, and some of the ones that do, sometimes there can, I don't see this as much anymore as many years ago. There may be a slight stigma associated with you're coming to a free clinic for your medical care. I don't see that as much anymore, but the visibility of our clinic, like I said, we've moved to our new facility, which is downtown Macon, Georgia. Um, so, so we're trying some new approaches about how to recruit new patients. In the past we've done. I mean, I'll still see little bus stop signs that have our phone number on it. So we're accepting patients. We've had, some print things, but now we're kind of going the other way around. Our executive director, operations type people are heading out and speaking with employers that have, like a lot of the restaurants, they have uh, workers that are making money, but they can't offer them health insurance because of the cost. So, or a lot of the hotels, the hospitality the industry, we're trying to actually go to the employers to actually say, hey, this is something that you can offer your employees. We can help you with that. So,
Yeah, because to me it's like if I have the option to go and see a specialist if or a professional at their craft for free, like I would definitely be looking to take advantage of that opportunity. I would almost be thinking like, hey, the problem should be the opposite. It's like there's too many people there's just not enough space for all of them. Demand's too high, but it seems like it's actually the opposite.
yeah. Well, and this connects with my emergency medicine side. A lot of the patients I see in the emergency department that don't have an emergency condition, that's something that primary care can do. They come to me in the emergency room because they do not have a primary care doctor. So this is a resource available for them to manage those things so they don't have to go to the emergency department. They don't have to get the enormous bill from the hospital for the emergency department visit. Plus, our from the emergency medicine side, we're an independent contractor. That's a separate bill. If the radiologist reads, any X-rays or CTs that they do, that's a separate bill. So, this it's a cost savings thing for the patient if we can get them into a primary care, whether it's us or a normal, so to speak, primary care office.
And so it sounds like one of the biggest solutions to this challenge is just more so awareness around number one, understanding what's acute versus non-acute, and number two, like you said, the approach that your executive director is taking around engaging more communities, more community leaders around, hey, like this is a very real option for those that aren't able to afford insurance.
Right.
Do you
Yeah,
see any other
yeah.
potential ways?
Well, and I have no control over this. And you talk to an individual physician, nurse, whatever. We have no control over this, but it's the mindset in Western medicine to switch from a curative model to a preventative model. You know,
Mhm.
so it's the you know, we want the quick fix to something that has happened as opposed to doing a little thing up front that's going to prevent it from happening. So the whole ounce of prevention is worth a pound of cure type thing. So,
Mhm. Mhm.
but we don't look in that direction. That's a different path down this road, which is a little rockier, so to speak. And if you just look at it, the easy path is just go do your stuff, and then we'll fix it on the back end. Well, a little more difficult stuff is to take care of it up front, but then that path is much easier down the road.
Got it. And shifting gears towards technology, what EHR do you typically use in ED, and as well as the volunteer clinic?
So in the hospital, it feels like Epic has taken over the world as far as EHRs. So we're on that, which is it is beneficial because I can see in that system, the other local hospitals in the area. I can
Mhm.
see what was done. So that's kind of opens things up. At the volunteer clinic, we use Athena, and the version we have is a free version that they have available for free clinics like us. So it's limited into what it can do. I don't have the capability of seeing outside information through other practices that use Athena.
Mhm.
It's just my people. So that's an extra step. We have to request records. So a little time suck right there. But that's how those are the two things I use.
And between all the different EHRs, EMRs, and PMSs that you tried, like, do you have a preference?
Not really, because they all have their plus and minuses, and the key for each EHR that you use is finding its pros and knowing what the cons are, so that you can sort of take those pros and embellish them, exaggerate them to work for your benefit. And then try and minimize what the downfalls are and find workarounds for it.
Mhm.
So I've in different places I've worked, I've used different EHRs. Epic is the most common one now, but I've used uh, WellSoft, Citrix, MedHost, all different types of ones. And so um, to me, it doesn't matter which one it is. It's a tool that I use to take care of my patients.
Mhm. Mhm. It sounds like you're able to find your way pretty much around any tool, and as long as you understand the benefits and detriments of each, you really are able to make it work.
Yeah.
And
If I know what I need to do, I'll figure out through the AHR what what is available to get done what I need to get done.
and other than EHRs and EMRs, what technology actually makes your life easier? Is there anything that you absolutely love using?
Um, well, from the emergency medicine side, again, these are one's a paid thing that I use, another one's a free one. I use the Corpendium, which is coming from MRAP Emergency Medicine Reviews and Perspectives. It's based out of Southern California. Um, uh, does a lot of podcasting, CME type stuff, but their Corpendium is their emergency medicine textbook that's online. It gets constantly updated with new research and things. So I use that as a basis, but for questions on what I'm doing at kind of real time, the new Open Evidence AI app is fantastic. I can put a specific question in, and it pulls out evidence-based, research articles, that type of thing, to answer the questions that I have. So those are the two that I use the most, especially during a shift.
America's #1 medical knowledge platform. That's super cool.
Yeah.
It's even got a free install over 100,000 downloads, 4.8 stars. Seems like a very handy app.
Yeah.
That's awesome. And we talked about what you sort of enjoy. Now, what technology makes your life harder? Is there something that you absolutely dread using?
Um, well, we're still in the emergency department. This is what this is our place that we use. We still have phones that I carry around, and so um, I'm constantly being interrupted talking to a patient by my phone ringing. There are different ways. Inside Epic, there's the chat feature. It doesn't get used near as much as it should
Mhm.
at our place. So that's one, technology thing that kind of annoys me. The other the other thing is in the EHR, and this is just the way, American medicine is going. Um, my hospital is part of a larger multi-state, multi-hospital company, and they're trying to align things. What is happening in one city, three states over doesn't exactly match what I'm doing at my place, but I still have to navigate their workflow.
Mhm.
So that's frustrating.
And so the phones would ring. Is that like the receptionist connecting you to the patients that have questions, or what would be like reasons for calling you in the middle of the workday while you're treating other patients?
Yeah, so these are our phones. So the phone gets passed on from provider to provider depending on the shift, and that's how our receptionist will, if there's it's not necessarily patients but other providers, that the other doctors that are calling in, whether it's somebody we have reached out to try and get in touch with, a specialist, or a consultant, but a lot of times it's, a pharmacy that's calling in, um, or another doctor that's calling in and say, "Hey, can you talk to this person?" I'm like, "I'm talking to a patient right now. I'm not the only one that's working here. I have other people. Can you try somebody else?" Um, those types of things. And, a lot of the interruptions that I get on the phone are things that have to be done over a phone.
Mhm.
Um, but it's the timing that can get frustrating. So a lot of times I'll have to excuse myself from talking to the patient and apologize profusely. I got to take the phone call. So yeah,
Mhm.
yeah,
Interesting. And I'm like, as you're describing this, I'm thinking to myself, like, how would a tech company solve something like this? Because something that we have is an AI phone agent. That's one of the seven agents that we have. So we have agents for documentation, we have agents for communication, and we have agents for like billing and insurance. And so, how would we like save doctors' time that are more so like there's doctors that are available and there's doctors that are not available because they're dealing with patients. How would
mhm.
the system recognize the fact that a doctor's busy? Well, maybe we can connect it to the EHR and know that, okay, at this time slot, the doctor is on call or seeing patients. Therefore, direct the call through the line to another doctor that is maybe free at that time.
Yeah,
But
or even, we have technology available that can track, where you're moving in the department. A lot of industrial engineering, like spaghetti diagrams where you're following people around. Why can that not be attached to the phone system? Well, if I'm in this location, don't call me. If I'm in a different location, I'm free to talk. That may be an option as well.
100%. Are you aware of any kind of tech that already provides an option like this? Like, do you guys have geo tracking within either the hospital or the clinic?
No, we don't have that tracking available right now. Like I said, I've seen it, but that's not something that my clinic is small enough. That's not an issue. But in the emergency department, I have not seen that in the hospital at all. So,
Absolutely. I imagine like with third party providers such as us, like we connect ultimately the key to all the doors is the EMR. So it's a
mhm.
question of integration if the EMR and one like Epic probably would be able to afford integrations like that. Uh, and it would probably be done via tracking with the routers all throughout the hospital
Hmm.
system. And the closest router that you connect to via Wi-Fi would be kind of the one that it would identify, okay, this person is in this segment in this area.
Hmm. Hmm.
So
Yeah,
100%, I think we're getting there.
yeah. Now the kind of that's definitely possible in rooms because there's a computer in every room, so that's connected. But in the emergency department, we have a lot of care spaces that are not in rooms; they're hallway beds.
Mhm.
So there's not a computer in that area dedicated to that space. So that could be that may be a hiccup in that system. Now the other side of it is, on my phone, I have the EHR and I use it to, AI dictation for my notes to put things like that. So that's always with me. That may be, if you, it's possible to put the map of the department into the system because I can see it. That may be a way to coordinate those two together. So.
And speaking of AI dictation, documentation burden is a huge topic in emergency medicine. How much time do you usually spend charting versus seeing the patients?
Well, my workflow and the way I document things, I can do a full chart in less than 2 minutes
Mhm.
using macros and those types of things. So I spend less time in front of the computer documenting than I do talking to the patient and going back and see the patient. Now, order entry, reviewing, trying to find different things, that takes a bit more time other than just straight documentation. But um, using the AI tools available has helped a lot with the documentation, whether it's the kind of co-pilot type dictation, where uh, ambient recording. I don't use that as much anymore because it picks up a lot of stuff that I don't want in my note. Uh,
Mhm.
so I use that ambient recording more as a I'm dictating into it, and it formulates it and puts together a little bit more coherent than my rambling myself. So, and then through the use of like macros and templates, that speeds up a lot. So, um, I don't spend as much time documenting as opposed to taking care of the actual patient.
Mhm. Mhm. And then you mentioned the AI tools for documentation. Is that something that's already built into Epic, or are you guys using alternative AI tools like third-party vendors to help with the documentation?
Yeah. Inside Epic, we're actually using the DAX Copilot
Mhm.
service. And so I can, but again, I just use that just for the history of present illness. I think it's able to do your exam, your medical decision making. I don't use it for that. We
Mhm.
we do use Dragon dictation in our charts as well. Um, the current version we have is not AI,
Mhm.
but I have heard through the grapevine that they are looking to put that AI module in with the Dragon.
That's super cool. Other than the AI with the documentation, have you seen any other AI that's been popping off throughout the practice or ones that you've tried that were super cool?
We have used, at one point, we were starting to use an AI service for stroke care. The CT scan would, in the system, would be read by um, it'd be seen in the AI system and it would notify us if it was a potential occlusion in a vessel. It could pick it up a little bit faster than our radiologist would get to read it. It was a very cumbersome system. I would get a notification about a patient that wasn't even mine. I would get notifications when I wasn't even working in the hospital. So that we haven't been, there were bugs in that one that we stopped using that one, but it's still there. But telehealth is still growing in our area too. So
Mhm.
that's another. It's not necessarily AI, but the technology side of it.
Nice. And so like more so telehealth, let's say from an app, or just it's becoming more and more popular amongst patients to prefer telehealth as opposed to becoming inside of the clinic, or is it more so that the clinics have doctors that are available via telehealth and they're talking to the patients remotely at the clinic, or how does
Yeah,
it
no,
work?
yeah, that's more on the emergency side. We don't use telehealth very much in our clinic here, but in the emergency department, especially at our place, we again for stroke care, we only have an in-house neurologist 7 a.m. to 7 p.m. So after that, we have to use teleneurology. So
Mhm.
they can talk to the patient, they can do a full exam with that. Same thing with psychiatric services. Don't necessarily have a psychiatrist available for mental health evaluations 24 hours a day. So um, uh, which that can cause problems if you have somebody that's having some psychosis and you have them talk to a television screen. That can make things worse. But that's a tool that we use frequently. So.
That's awesome. And tracking that we're almost at time here. If everything goes the way you're hoping, what does the make and volunteer clinic look like in 3 years?
Well, if everything goes like I want it to, in 3 years, I don't see much of a difference other than I want my waiting room a little fuller. Um, I've got extra space here that we're not utilizing yet for patient care. I want that to be fully utilized with a full waiting room with patients. And to do that, that's going to be more volunteers, more people wanting to help out because this is a service that is well regarded in our area by the ones that know what it is. We are fully funded by grants and donations. We get no federal government money to do this. So the ones that know about us are very happy we're here and do what they can to help us. We just got to get more people to know that we're here.
Yeah, that's amazing that the community is really coming together and making sure that people are taken care of. What about emergency medicine more broadly? What changes do you hope to see in the next decade?
For the emergency medicine side, it's not so much emergency medicine as it is systems-based type things. So, um, the breaking down of the silos in the hospital. We are not the emergency department. We are the area in the hospital. Um, it's not a separate, you know, surgery wing. It's not a separate OBGYN wing. It's one system that works together. So I can help you do your stuff, but you have to help me get your patients through and get them out so that I can get this patient to you so you can take care of them. So the coming together as one unit from the whole healthcare system from what happens before the hospital, what happens in the hospital, what happens outside after the hospital stay. Streamlining that process would be what I would really love to see over the next 5 to 10 years.
When we say streamlining, is it more so the communication or what kind of systems?
Oh, yeah, yeah, it's all of it. It's the communication, the availability of services, and part of that will have to go toward the reimbursement side of it. So getting these services paid for. It doesn't matter if it's available. If nobody's paying for it, nobody's going to utilize it. So,
Makes sense. And where can people find you? Mind sharing a little bit about Rebel EM or
yeah.
some of the other social platforms where
Yeah,
people
I
can
mean,
find you?
Rebel EM is, it's a blog and podcast. I haven't seen too many podcasts come out recently. I'm not as on that as much as anymore, but it's just rebelem.com. And so the blog post, it's actually the Rebel actually stands for Realistic Evidence-Based Evaluation of the Literature in Emergency Medicine, so Rebel EM. So we regularly put out posts related to research that's come out to help with that. So that's where that is. My best friend from residency, Salim Rizai, he is the Rebel. He started this and he's running this. Um, so that's fun. But other than that, I'm available, through social media, LinkedIn, those things. Matt Astin, or M Astin MD on all the socials that I'm available. X, Instagram, LinkedIn. It's Matt Astin. So
Amazing. And anything else that we didn't cover that you want to share?
not really. Other than we're still in the early infant stages of mixing medicine with technology, especially AI. So Um, I'm really excited to see where things are going to go. I'm just hoping that my career's not over when it really takes off. So I still have another, 20, 25 years, but still,
100%. And people always prefer people over machines. It's
yeah.
so interesting, even with some of the content that we put out there, even targeting the very manual work, such as patient communication and people calling into the clinics and presenting the scenario to the patients of like, hey, like there's no one to reach uh, at 3 a.m. and you have to take care of your infant daughter who's sick, and the AI is there to book in the appointment for you. People still have a stigma against it, and they're like, hell no! Like the moment I hear AI, I'm hanging up. Like people will prefer human beings. I feel more and more as
Mhm.
time goes on, especially in the early stages of AI, while it still hasn't really bloomed into something
Yeah.
that is inseparable from a human voice and human interaction.
What a lot of people need to understand from the user side of it is AI is just another tool that we use. It doesn't replace things. It doesn't replace you. It is a
It
tool that
augments.
you use to augment what you are doing. So,
Absolutely. And it's something that we communicate to the staff as well with the clinics that we work with. It's like, hey, like to the front desk staff, or like we're here not to like steal your jobs. We're here to give you your time back so that way you're not in pulled into four different directions at once and not
mhm.
being able to help patients there in person and instead having to be on the phone calling up and trying to reschedule stuff when it could be done very easily by the AI, by the phone system that we implement.
Yeah, it allows the human to do the human things that they're good for. Other things that can be automated, let that go ahead and automate it so that you can put more time into the human element.
100%. And Matt, thank you for the time. I know we went a little bit over. I love talking to people who are building things in multiple directions at once, the emergency medicine work, the volunteer clinic, the education piece. It's really a reminder that you can do a lot of different things well
Yeah.
if they fuel each other. And for the audience, if you enjoyed the conversation, check out our other episodes of The Operator. We talk to physicians, office managers, front desk staff, and everyone in between about what it's actually like to run a medical practice. Uh, Anything else to add, Matt?
No, it's been my pleasure to be here, and I hope that um, I provide a little benefit, a little education for some people. But feel free to reach out to me at any time. I'll answer as many questions as possible and try and help out as much as I can. So,
Beautiful. Thank you so much.
thank you.